All right, if you're gearing up for your anesthesia finals, you know there are these classic topics, right? The ones that are kind of rare in day-to-day practice, but are almost guaranteed to pop up in an exam. Well, latex allergy is the perfect example. So let's break down everything you need to know, the high-yield stuff to make sure you're ready for it. Let's kick things off with a real-world puzzle. Picture this. A 53-year-old healthcare worker comes in. She tells you about these scary reactions she's had at the dentist. Facial swelling, fainting. One time it was so bad she needed adrenaline. Her dentist told her she was allergic to local anesthetics, but, and this is the key, nobody ever actually tested her. Classic clinical conundrum. So what happens next? She gets properly tested for the local anesthetic allergy, and guess what? All the tests come back negative. This is where you, as the sharp anesthesist, have to step back and ask the critical question. If it's not the drug everyone's been blaming, what's the real culprit here? What's the hidden danger in the room? Okay, here's our game plan to get to the bottom of this. We'll start with the allergic reaction itself, then move on to spotting the at-risk patient. We'll cover how to actually confirm the diagnosis, what to do in the operating theater, and stick around for the end because we're going to talk about a new threat that's on the rise. First things first, we've got to dive into the basic science. And honestly, this is fundamental because if you get how latex causes a reaction, everything else we talk about is going to make so much more sense. So, natural rubber latex, or NRL, comes from the Hevea brasiliensis tree. It's this milky liquid. But here's a cool little fact. The proteins that cause the allergy, they're actually the tree's defense mechanism. They're produced when the tree is stressed. So the more a tree is tapped for its sap, the more allergenic that latex can become. Now, this is a super important distinction for your exams. The body can react in two totally different ways. The type 1 reaction is the one we're really worried about in anesthesia. It's immediate, we're talking within an hour. It's IgE-mediated, and it can spiral into life-threatening anaphylaxis. This is a direct reaction to the latex proteins. Then you have the type 4 reaction. This one's delayed, taking a couple of days to show up as a nasty rash. It's T-cell mediated, and crucially, it's a reaction to the chemical additives used to make the gloves, not the latex itself. It's uncomfortable, but it's not going to kill you. And just to add another layer, it is so important not to confuse that type 4 allergic rash with a simple irritant contact dermatitis. Irritant dermatitis is actually the most common reaction people get from gloves. It's not an immune reaction at all, it's just physical irritation. But here's the danger. That irritation can cause tiny breaks in the skin, which then act like a gateway for the actual latex proteins to get into the body. And that is what can lead to true sensitivity and set the stage for a dangerous type 1 allergy down the road. Okay, that's the science. So how do we actually use this in the clinic? How do we spot the patient who's a ticking time bomb before they even get to the operating theater? Well, there are some well-known high-risk groups that should be setting off alarm bells in your head. Patients with spina bifida or urinary tract problems are at the top of the list, mainly because of all that repeated exposure from catheters. Also, keep a high index of suspicion for patients who've had tons of surgeries, for us healthcare workers, and for anyone with a history of atopy, especially eczema. Your absolute best friend here is a good, focused allergy history. You need to be asking the right questions. Ask about their exposure history. Ask about those classic allergy symptoms around things like balloons or rubber gloves. Ask about any weird reactions to certain foods, and get their general atopic history. And seriously, do not skip that question about food. It's a massive clue. This thing called the latex food syndrome affects up to half of all people with a latex allergy. It turns out that some of the proteins in latex look really similar to proteins in foods like bananas, kiwis, and avocados. So if your patient tells you their mouth gets all itchy when they eat a banana, that is a major red flag. Okay, so you've taken a great history and your spidey sensors are tingling. You suspect a latex allergy. How do we actually prove it? What's the formal diagnostic pathway?
Well, the gold standard is skin prick testing. It's got a really high sensitivity, sometimes up to 100%. If you can't do that, there's a blood test for specific IgE antibodies to latex. It's totally safe, which is great, but just be aware that its sensitivity can be a lot lower, sometimes missing almost half the cases. Now, if you have a patient you're really suspicious about, but both tests are negative, a specialist might do what's called a provocation test, where they very carefully expose the skin to a piece of latex glove in a super controlled setting.
Right, let's get to the sharp end. This is the most important part for us. You have a patient with a known or even just a suspected latex allergy on your list. What's the plan? The name of the game here is total
absolute avoidance. You have to get every single latex-containing product out of that room. And don't forget about the rubber stoppers on drug vials. Here's the key detail. If that theater has been using powdered latex gloves, the allergens can actually hang around in the air. So the room needs to be rested for up to 3 hours to let everything settle. And please remember this. Giving steroids or antihistamines beforehand is not recommended. It will not stop a full-blown type 1 reaction.
All right, to wrap this up, let's just zoom out for a second, because the whole story of latex allergy has taken a massive turn over the last couple of decades, and frankly, a new villain has entered the scene.
I mean, this slide really shows an incredible public health success story. Because we got smart, we banned powdered gloves, we raised awareness, the incidence of latex allergy has absolutely plummeted. Just look at these numbers from France. Latex used to cause 20% of perioperative anaphylaxis cases. Now, it's down to just 5%.
And that trend is definitely happening in the UK too. The massive landmark 6 National Audit Project, or NAP6, which looked into severe perioperative allergies, found, wait for it, 0 confirmed cases of anaphylaxis from latex. 0. The threat has become incredibly rare.
But you know, just as one threat starts to fade away, our focus has to shift.
So if latex isn't the big bad wolf anymore, what is? What's the new hidden allergen lurking in our operating theaters? The answer, according to that very same NAPS study, lies in this number. 9%.
9% of all life-threatening allergic reactions in the perioperative setting were caused by chlorhexidine. That skin prep we use on literally everyone all day long, it's so common we don't even think about it, and it's now a major cause of anaphylaxis. It has, for all intents and purposes, become the new latex.
So I'll just leave you with this question to think about. We've pretty much gotten on top of the latex problem, but when you walk into your theater tomorrow, what's the most overlooked allergen in your environment? What are we all missing? By the way, all the info we've covered comes from this fantastic paper in BJ Education from 2020. I definitely recommend giving it a read. All right, that's it for me. Good luck with the revision.